The cardiovascular screening exam is important for assessing cardiac and vascular function in any patient. It is often taught first, given the frequency with which we see cardiovascular issues across all specialties, and given the urgency with which many cardiac diseases need to be recognized, assessed, and treated. During the cardiovascular exam, you will progress through the clinical techniques of inspection, palpation, and auscultation to examine the components of the central and peripheral vascular systems. Percussion is rarely performed in the cardiovascular exam because it does not provide much in terms of clinical decision-making. Throughout most of this clinical reasoning series, we recommend that you learn and perform the entire screening exam from head to toe. Although we teach all of the components of the exam for each system separately, including those of the cardiovascular exam, you will eventually learn to integrate all of them into one cohesive, comprehensive, and coordinated screening physical exam. Your patient's modesty and comfort should be considered when approaching the removal of the gown for the cardiovascular exam. It is usually acceptable to ask male patients to lower the gown away from their chest down to their waist. When assessing female patients, expose only the area being examined at the time for their comfort and security. However, remember that these standard practices may not apply to every patient. If a patient expresses reservation or discomfort when you ask them to remove their gown, listen to them and respect their needs. This not only shows appropriate respect for your patient, but also helps develop trust. For much of the cardiac exam, the patient will be seated in an upright position. When it is necessary to transition them to another position, this will be noted. What each position looks like and how to help your patient move into different positions comfortably, efficiently, and safely will be detailed in a video dedicated to etiquette. Anatomy review. Recall the anatomy of the heart and its position relative to the rib cage. The heart is located primarily in the left anterior thorax. The apex of the heart extends inferiorly to the fifth intercostal space and laterally to the left midclavicular line. The right ventricle is the most anterior part of the heart. It is posterior to the sternum, and it extends just beyond the right sternal border. The left ventricle is the largest chamber of the heart, and although it does contact the anterior chest wall, it is mostly posterior in comparison with the right ventricle. Both atria are posterior to the ventricles. The base of the heart is made up of the aorta and pulmonary artery. Although the aorta leaves from the left ventricle, recognize that it loops over the pulmonary artery and arches to the left before descending posterior to the heart. Likewise, the pulmonary artery leaves from the right ventricle, which is positioned on the left side of the patient's chest. To confound things further, the valves are located within the heart, and we will discuss them more later. Inspection. As with all systems you examine, you should begin with inspection to look for any abnormalities apparent at rest and observe any changes that occur during certain physiologic movements or simply when changing positions. Although the heart is considered the most prominent part of the cardiovascular system, you should consider anything from head to toe that reflects underlying dysfunction or pathology. Starting with the head, look at the patient's expression and relative comfort level while talking and breathing. Notice their skin color, looking for signs of increased blood flow, such as erythema, or signs of decreased blood flow, from mild pallor to cyanosis. In the neck, assess for pulsations of the arterial venous flow. Looking at the anterior chest, note its movement with each breath, and pay attention to abnormalities of the chest wall. Look for the point of maximal impulse, though it may not be visible in all patients. Moving inferiorly, notice any vascular changes in the skin or visible pulsations in the abdomen. In the lower extremities, look for changes in the skin's tone, color, and elasticity, and note any lesions or breakdown, as this may reflect underlying vascular dysfunction. Palpation. Once you've completed your inspection, giving the patient time to become accustomed to your presence, you will move on to palpation, using your hands and fingers as the tools of evaluation. We'll start with the heart, then we'll move on to palpation of the vasculature from the neck down. First, locate the point of maximal impulse with your fingertips. If it was not visible on inspection, begin your search by using the flat of your hand, parallel to the clavicle, at the fifth intercostal space near the mid-clavicular line. If the heart is of normal size, the point of maximal impulse should be palpated close to this area. Next, place the flat of your hand over the sternum to feel for any unexpected or abnormal movements of the heart, such as thrills, lifts, or heaves. After you've assessed the anterior chest, move on to the vasculature. On a screening exam, there isn't much to palpate on the head, so you'll start at the neck. Using the pads of your fingers, palpate the carotid pulses, one side at a time. Palpating them simultaneously can result in syncope. Next, assess the brachial and radial arteries in the upper extremities, and capillary refill time in the fingernails. The abdomen is palpated with the patient lying supine. So help your patient to transition from an upright position to a supine position. In addition to palpating the abdominal aorta, you must also estimate its size or diameter. From here, move inferiorly to palpate the femoral, popliteal, dorsalis pedis, and posterior tibialis pulses. Assess all pulses for presence and strength on both sides of the body, and check for symmetry. Auscultation. Many new students consider auscultation of the heart to be the primary physical exam maneuver for assessing cardiac function, but by now, you should know that it's only part of the picture. Cardiac auscultation involves using a stethoscope to evaluate the pattern and intensity of blood flow through each of the heart's four valves: the aortic, pulmonic, tricuspid, and mitral valves. You can remember the order of assessment with a mnemonic: all patients take meds. Both sides of the stethoscope chest piece, the diaphragm and bell, are used to listen over each of the four valves in order to identify blood flow abnormalities that require further workup. Once each valve has been evaluated in an upright position, the patient is guided into different positions to amplify and clarify any abnormalities heard in the initial exam. Once auscultation of the anterior chest wall is complete, help your patient into a supine position to auscultate the abdomen. Listen to the abdominal aorta and the bilateral renal, iliac, and femoral arteries, assessing primarily for bruits, or turbulent blood flow through the vessels. The complete cardiovascular exam consists of inspection of the full body, paying particular attention to visible pulses, the anterior chest wall, and skin changes that indicate cardiovascular pathology. Palpation of the point of maximal impulse and the major arterial pulses of the body, from the carotids to the dorsalis pedis. And auscultation of the heart, the abdominal aorta, and the renal, iliac, and femoral arteries.